Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols. Hey everybody, people love the random ramblings episodes, so they tell me. This is one of them. I had my buddy Moose, you guys know him and love him, from Alert Medic 1. I should have silenced my alerts, but just to give you a heads up, we had some technical difficulties on this episode. Not on my end, of course, but I'm just joking, but that is honest. So it may skip a little bit. There were a couple little like editing parts where the conversation may abruptly break off and then we pick back up. So I do apologize for that, but it's a good episode. We talk about a lot of good stuff. My buddy, Mr. Sidik, is a great guy. Without further ado, here's the episode. So, this has been in like months in the making. We've been trying to link up and do this in person, but it's just not happening. So we need to shit or get off the pot and do this virtually. Yeah. So Moose from Alert Medic 1. What are we talking about?
So much. First of all, I just really appreciate you having me on, man. I
think you guys have an open invite. You know that.
No, I appreciate it. And I'm the biggest, I'm guilty of it, just, I think I had to reschedule on you like 3 times, Sunday or Saturday when we were going to record.
So did I on you.
Yeah.
So
yeah, I was, I sent you the picture. I was balls deep in my Land Cruiser. I ended up working on that till midnight, like straight through 9 a.m. to midnight, just the one side redoing the front end. And it was a bitch.
Yeah, it didn't look like a quick fix from what you were sending me.
No. So, man, this lighting is really, that's project number 1 after we're done recording. I think that looks a little better. Yeah, man, it's been a minute, and I just want to say I appreciate you allowing me on, and I really appreciate the stuff that you're doing, right? Full disclosure, I think I've talked about it on the Alert Medic 1 podcast before, but I use this app called Unplugged, UNPLUQ. So, because I realized I had like a social media problem. So, full disclosure, I don't take in your content as much as I probably should, but that's a symptom of me blocking social media now 24 hours a day during the 5-day work week, and then on the weekends from 9 to 5. But everything that I do see you post, I think you do a fantastic job of really diving into literature, but also understanding your limitations. You know what I mean? And I think you've been a great mentor to folks and a good example of how, an EMS commentator should be, right? And I just want to say that, as we start recording,
well, thank you.
Because there's plenty of bad examples.
Oh, well, thank you.
Right. Of course, man. Of course. And we've talked about it a little bit,
AI, like people who use AI to do all of their content.
Well, hey, I mean, listen, I'll be the first one to say that I use AI, but when I do use AI, especially lately, as I've become a better steward of it, I think I try to give credit, right? I mean, if I, even in my academic world, when I'm writing like a paper or something like that, there's no issue with saying, hey, I use ChatGPT for XYZ, and you end up getting the full point. Right? And I think in terms of listenership, I think for the most part, and I'd love to hear your take on this, if people are just authentic with the folks that they're listening to and say, hey, listen, I either, if you mess up, you tell them you mess up. If you use AI, just say, hey, I used AI this way, right? I'll tell you right now, for the record, I'm working on a Ross a series, right? Like I want to do a probably a 15-part series, a deep dive on the renin, Ross, Jesus Christ, renin, angiotensin, aldosterone system, right? And but I'm using ChatGPT to help organize my thoughts, organize everything. But when I publish that, I'm not going to say, oh, look, I just wrote this 150-page thing. No, that's stupid, right? I mean, you got to give credit for where credit's due.
Yeah, 100. Hold on, let me put this on Do Not Disturb. I thought I did already.
No, you're fine. I should probably do that too.
Yes, no, I agree with you. Why can't I talk? Authenticity is critical. I don't know how to use AI for the most part. Despite having a podcast, I am not tech savvy. I'd like to learn to use it, and I am not opposed to, instead of doing hours of research, going through papers on PubMed and being like, oh, look, this was written in 1963. This was written in 2012. So this would be a better source. I am not opposed to using ChatGPT to help me, or whatever program to help me find literature. But the problem I have is when people write a blog post as if it was their work
Yeah.
and they put their name on it and it clearly was written by AI. Like they may put in a little flair, like, so I was working the medic unit last night and I responded to a difficulty breathing call and the patient had crackles and wheezes and I didn't really know what was going on. I was between CHF, COPD, pneumonia, or a combination. And then it goes into, here are 15 different points to help you identify the difference between the two.
Yeah.
Then they put their name on it.
Yeah. I gotta say, I've seen that, man, and I'm not a fan.
Yes.
I'm not a fan, especially as someone who uses AI a ton. Again, I don't want to say sound like a naysayer for AI, but you got to give credit where credit's due. I've made that mistake. Alert Medic One has made that mistake too. Like, as in, when I've posted stuff, Josh does a fantastic job, by the way, for our social media. You know, for the listeners here, if you guys are ever interacting with the social media for Alert Medic One, it's not me, it's not Ken, it's not Cody. It might be Cody, maybe. But for the most part, it's Josh, and Josh does a tremendous job. And you know, I went Thanksgiving a couple years ago. I posted some stuff, but I never said that I made it with AI. Now, a keen eye can say, "Hey, that was made by AI," right? But as the world discovers the use of AI, like especially, and when we say AI, I think Mike, I think you're talking about like ChatGPT and stuff like that, learning language models. I think we need to be better stewards of what we're doing for our listeners because we owe it to them, right? I mean, they're the ones that are listening to us on the way to work, on their way to class, and I just think it's dishonest to say, you know, if something is yours when it isn't. I don't know. It's tough.
I agree with you. You're in grad school, or yes, you're in grad school.
Yeah,
I know you're trying to go to medical school with as an end goal.
Yeah. So I'm finishing up I have a semester left at UMBC. I'm getting my master's degree in epidemiology and preventative medicine. And the goal is to get to medical school. I'm actively studying for the MCAT. I'll tell you what, it's a bitch. Working full time, having a significant teaching load, and doing the podcast and studying for the MCAT. But I'm making it work.
But when I was in grad school, this was in 2007 at the University of Delaware, I was so absolutely paranoid about getting, obviously I wanted to be ethical, clearly, but I was also very paranoid about getting banged for plagiarism, like inadvertently, because if you're not careful with your citations, you can really get fucked over. Like Doris Kearns Goodwin, like the renowned historian, she was supposed to be my commencement speaker and it got yanked because she was going through a plagiarism controversy. And it turns out that she's been like a revered historian, not like she is a revered historian. And it turns out one of her research assistants was doing sloppy citations and she didn't pick up on it. And she finally came forward and was like, look, like, yes, I own this. You know, my research assistant was a bit sloppy on the citations, but I don't blame he or she. You know, it's ultimately on me and I didn't pick up on it and I didn't cite what was written in the book. So I was very paranoid. So I think I have carried that over into doing what I do because I must give credit where credit is due. And I think you wanted to talk about like what makes an expert.
Yeah.
I think this is a good way to dovetail into that.
Yeah, and I'll give listeners a little bit of what Mike and I. Again, we've been trying to plan this for months, and I wanted to give the show, I wanted to make it a good one, right? I wanted to put in the time, and I wanted to, I take your listeners' time, and my listeners' time, and I take this seriously, and I didn't want to just bullshit on something that I didn't know about. And full disclosure for your listeners, right? A little bit about me, if you're not familiar with who I am. My name is Mustafa Sidik. Right now, I work for a state EMS office. I am a paramedic. I was a paramedic in the field for a little bit over 2 years. I still am a paramedic with that agency, but I just work part-time for them. And I'm not the guy that goes to, I'm not on a truck for 40 hours a week, right? So I don't want to come off as one. I've been blessed with opportunities to teach, and I teach a ton, and I do try to pick up as many shifts as I can, but I would never put myself in a position of someone that is actively in the field doing the work, which, I mean, to be very clear, I have the utmost respect for those people, because I know how hard it is, right? I personally am not built for a 24/72. I have so much respect for people that run 26 calls on 24-hour shift and somehow still get held over. So when we were thinking about when I was thinking what we wanted to talk about, this conversation, and I've been mulling this over for a while, because like between your posts about like the EMS chief, like medals, and like on the internet, you see, especially LinkedIn is rife with folks that, I think some of them come out and say it, right? Like, I'm an expert in XYZ, right? The others say, insinuate heavily that they're an expert in XYZ. And I wanted to talk about what is an expert, right? And then last week there was, Rogan had this comedian Dave Smith on with this, and I don't really know too much about the other guy, Douglas Murray, and they basically attempted to have a debate about like the Israel Palestine stuff. They had like Ukraine thing, but one of the arguments that Douglas Murray made is like you have to have expertise and experts on, and to, I guess, basically make a good argument for any topic that you're talking about. And then the other thing was you have to have the lived experience of whatever you're talking about. So I wanted to start with you, Mike, on those two things, if that's okay. In the context of EMS, what makes an expert, and what is the value of lived experience, in providing education, in providing expertise, in providing XYZ? I guess we can start off with that.
Well, if you wanted a literal definition, I have been deemed an expert in EMS by a court, because I used to do expert witnessing. Some courts you need to get certified as an expert, others you can just show up and testify. But the definition, I'm not an attorney, but from what I remember, the definition of an expert to testify in a trial is somebody who knows more than the average person about a particular topic. So I have always had, and I'm going to sound like a weirdo here, and people are going to be like, huh? I have always had a very, very strong interest in the history of Nazi Germany.
Mm-hmm.
I have read a ton of books on it. I have watched every documentary known to man on Nazi Germany and how they came up, how the German people got on board. Technically, according to a court, I could be an expert witness on Nazi Germany.
Sure.
But I think if we're talking more generally about expertise, I do think it's a combination of knowledge and lived experience. You can't just do lived experience because people live in their bubble.
Mm-hmm.
And also, EMS wise, we know people who are 35-year know-nothings in this profession. And then on the flip side, you have the LinkedIn crowd who may have done actual EMS for 1 year and has not touched a patient since, but they think they know everything there is to know about EMS, but they don't have that lived experience. So it's kind of a philosophical conversation, which is why we're here. But I think it's kind of like a case by case and scenario by scenario basis. Like if you wanted to talk about administrative matters and the legality of EMS and how the state certifies and conducts EMS, you're the guy to go to. I don't know jack shit about that stuff.
Yeah, I don't know if I would be the guy to go to either. That's the problem, right? Because
going back to that court definition, you know more than the average EMS provider about that stuff.
Sure. And it's interesting you brought that up. I wonder if the societal accepted, what we think of as an expert is different than what like what the court just said, right? Because like, yeah, I mean, if you were to ask me about like state certification or whatever, right, XYZ, I would know, I guess, more than the average person. Or I wonder if anywhere in there comes like more than the average X, right? So like a paramedic that knows more than an average paramedic for a court case or something like that. The I think it's a little bit, I don't know, maybe this is how I think. the benchmark is set a little bit higher though, right? So like when going back to your example of like World War II, Nazi Germany, I would go to folks that have, and I know this is going to get us down a rabbit hole, okay? And I'm not like this shill for academic medicine or anything like that, but like I would go to like a professor of some of not Nazi Germany, right? Who would like has gone through and done the work and done the research, has maybe gone out and done like actual field work, so on and so forth. That when I first think about it, I think of that as someone who I imagine would be like an expert, right? Um, Coming to EMS and medicine, I think I look at folks who have both parts education and experience, right? So folks that have gone beyond a bachelor's degree, and honestly, the substance of that bachelor's degree matters, and also the substance of the bachelor's, master's, doctorate, whatever matters. But also, EMS is such a wide topic, like you just said, right? For state functions, stuff like that, I might be your guy, but I'll tell you what, don't ask me anything about vents. I mean, I did vent a
Sure.
guy, a couple years ago, right in pre-hospital medicine, because I was, in where I work part time, we have vents, and I had to do it, and I figured it out, right? But I'm not your guy for vents, right?
Mm-hmm.
I'm going to be coming to someone like you or someone like Cody. I know the general logistics because I have an understanding of exposure to standing up a whole blood program, but I don't know the ins and outs of it. I'm going to be going to somebody like Josh who has a way better idea. Ken, who is now running a paramedic education program. If I have questions about CAPS or anything like that, I know a little bit, but I would turn to him. So it's I guess it really comes down to what specialty you're in, and how you can, I don't know, justify the label. I will say real quick, if anyone calls themselves an expert, I'd be cautious.
Yes. I also am. I definitely value degrees. I am not a degree hater because obviously I have degrees. Uh, I'm cautious when people use their education as justification for them being an expert in something. I have a grad degree from the University of Delaware in healthcare administration. I graduated from the University of Delaware with that degree knowing fuck all about healthcare administration. I know nothing about it. And I had a 3.9 GPA. I was on the governance committee of the program. If you put me in a hospital and said, hey, you are now the assistant chief operations officer, I'd have no clue.
Yeah.
So degrees, while they do make you well-rounded, they do give you some education in a particular area. I mean, granted, I guess it's different if you're getting an engineering degree or an accounting degree, but these broader degrees like emergency services management or administration, I got to ask, like, does that really make you an expert? Now, I have a hard no politics rule, and I am not bringing up politics here, but I was having this discussion with my dad because, and I'm not telling anybody my politics. I always play devil's advocate, whether I agree with it or whether I don't agree with it.
Yep.
My dad hates Donald Trump with every fiber of his being. He hates Robert F. Kennedy. And my dad is a now retired neurologist. And my dad said, what the hell does Robert F. Kennedy know about epidemiology and health policy? He goes, he doesn't have a medical degree. And I love that your cat's on the screen.
Sorry.
No, you're good. I mean, I have 3 cats myself. That's funny.
Yeah.
But so he said, what the hell does he know? He doesn't have a medical degree. And I said, to your point, I said, to play devil's advocate, what the hell do you know about epidemiology and health policy? And he was like, I guess you have a point.
Yeah.
So I am cautious about degrees. I am also cautious about people who only use their life experience to make them experts.
Yeah, I always say that no amount of experience in the back of an ambulance is going to teach you like any sort of physiology, right? Like you can't understand deeper.
No. You can correlate things. You can be like, I've seen this before.
Yeah.
I think this is going to lead to this happening.
Mm-hmm.
But
you never, you're never going to know the underlying, the physiology underneath it. But on the same token, you can have as much of a college education as you want, but until you've been there telling a mother that their kid's dead, right? You've never experienced that either. And there's no amount of education that's going to give you that. And that's why there's this dichotomy and there has to be a balance, I think. And when we consider experts, when I consider experts, I should say, I envision folks that have walked the walk, that they've talked the talk, but also they've been in it for a minute, right? And that was one of the questions I was going to ask you. Like when I look at uh, how should I say this? Well, you brought up a good point about your dad, right? Like what part of essentially I distilled that to what part of medical school taught him about epidemiology? Nothing, right?
Yeah, nothing.
The for someone like me who's going through a graduate program in epidemiology, my mind was continuously blown by classes that I was like, oh God, I didn't even know that I didn't know that XYZ topic. And when I think formal education plus the experience gives you that maximum opportunity within the correct programs to learn what you don't know. And I think I talked about that previously when I came
Key.
on your show. Yeah. You know,
Yeah. Key. That is key. It is the proper thing to say, people to say, like, well, yeah, I am an expert, but like, if I don't know the answer to a question, I'm going to be honest. People always say that,
mm-hmm.
and they may believe it, but there really is something to be said about not always having an answer and just being able to throw up your hands and say, I have no freaking idea. And I think in today's age of social media and, the general news media, with whatever side you're on, with these like gotcha clips,
Mm-hmm.
I think people are expecting that if you don't know the answer to every question, or you stumble over your words, or you get something wrong, that automatically negates your expertise in a particular area. Like, I've said things on the podcast before that were wrong. And
Yeah.
I've had people DM me and they were like, hey, you're incorrect. Like, here's 3 articles to show that you're wrong. Okay,
Yeah.
fair enough. Like, does that negate that I am a decent podcaster, a decent educator? No. Just like if a doctor, let's say you become a cancer specialist and you have a patient come in with breast cancer, and you treat a certain type of the cancer, you misidentify it. Whether you screwed up or whether the science was limited, does that negate your ness, your value as a
Yeah.
physician? No, it
No,
doesn't.
it doesn't. Exactly. Yeah.
Not at all. People fuck up. And there are limitations to everything that we do. And I think that people expect in today's day and age that experts are going to be able to be an expert on every facet of a particular area. And that's just not the case.
I think it was one of the Mayo brothers has a famous quote that from the Mayo Clinic that medicine has gotten to the point where no one person can learn its totality, right? And I think that's a great example of just knowledge in general. Like the world has become so complex that you can try to be, you know, the best of the best at anything. But I mean, I'll tell you right now. So I was teaching a 12 lead class for one of the paramedic programs that I teach at, and I for this particular program, all I do is their 12 lead stuff. And they asked me a question that basically how to name a 12 lead that has multiple different we see elevations in multiple leads, right? So if I have elevations in the inferior leads and the septal leads and the anterior leads, how do I do that, right? Or if I have
Mm-hmm.
depression in inferior leads but I have elevation everywhere else. And the way I was taught was you take the first 2, right, that appear to be the most elevated, and you just go with that, because what you don't want over the console box is to sound like you're saying a bunch of shit like enter subtle. No one cares, right? Especially in the world of transmitting, you say what you the 2 contiguous leads or the 4 contiguous 2 contiguous leads that have the most elevation, and you just you call it that and you go on with your life, right? You do the rest of the thing that you're supposed to do, which means treat the patient. But then I talked to the medical director of the program, because when they asked me that question, I said, listen, this is how I was taught, but I don't know, right? I don't know if I'm 100% correct. Why don't I go ask the medical director of the program, which I ended up having a phone conversation with him. And he said, hey, just call out all the areas, right? And if you sound like an idiot, you sound like an idiot. And I'm like, okay, cool. It is what it is. He didn't say exactly that, but like that's kind of what I distilled out of it. And the other thing he mentioned was, in the world of transmitting, it's not that big of a deal. But, I try to be that instructor, especially when I'm in the front of the classroom. The first thing I told these guys when I started with them is, listen, today I am in the role of an instructor and you are in the role of a student. But I'm hoping that tomorrow that's a different, not literally tomorrow, but tomorrow that could be flipped, right? I just happen to have a set of information that I've been credentialed to teach you. But that doesn't mean that I know everything. My way is not necessarily the highway, but it's the way that the program has said that we're going to teach. And if you find a different way, bring it up. I'm all about conversation. I think where folks get in trouble is when they quite literally say, no, my way is the highway and everything else is garbage. Because
Yes.
that's a sign of a very dangerous clinician, in my opinion, and educator.
You see that a lot in healthcare too, because what we're really good at, and guilty myself, is talking shit about other healthcare providers.
Yep.
Like, we brought that patient up to the ER and they sat on that patient and they ended up having a giant STEMI and didn't get to the cath lab like 3 hours later. Yeah, they may have messed up. They may have been in the right. Yeah, there are more than one way to skin a cat. Surgeon A may want to take the spleen out. Surgeon B may want to leave it in, and both could be completely correct and appropriately manage the patient.
Absolutely.
And people would talk shit and be like, "Oh, that surgeon didn't take out the spleen," or like that, or that one, went right to ripping it off. We're really good about talking shit in healthcare, especially us, because in EMS, we know. I said this on the last podcast I did with the listener question episode with Ashley. We learn a lot about a lot. Or I said that wrong. We learn a little bit about a lot of topics.
Yeah.
We don't have deep knowledge in a lot of areas.
And we have we have a crappier foundation in a lot of topics, right? So I'll give you an example. I didn't know shit
I mean,
about
Nancy Caroline's not like the end all be all foundation of knowledge.
The problem is, like, I think we're in this world where we're given a little bit of education. I'm going to say this: a lot of times we're taught by people that don't know the underlying medicine. And then we get to go out there and do a lot of cool shit and get to have a high impact. So then we like have a little bit of a chip on our shoulders. And I think that really goes to that Dunning-Kruger complex where like you think you know more than you know. And it's just not the case, right? What really opened my eyes to like, for example, the underlying physiology, and I keep coming back to that because I ended up earning a bachelor's degree in physiology that's helped me tremendously. You just don't know what you don't know. Like I went, as I was a paramedic, basically I went to undergrad, essentially dropped out of undergrad. I went to part-time status to go to become a paramedic and was working as a paramedic. That's what ended up helping finish up my bachelor's degree, paying for my bachelor's degree. And when I went back, I realized, oh my God, a lot of the stuff I learned in paramedic school is either A, incorrect because it was incorrectly taught to me, or B, it was taught to me, but I built this house on a shitty foundation because that foundational knowledge wasn't covered well. And when it comes to, I'll give you the same example, right? Like, you show up to the hospital and you are absolutely sure that you're seeing a STEMI, right? Because, you took, I don't know, not only did you take the paramedic school, but then you went to Tim Phelan's class and you did a bunch of other stuff. And now, like, you believe yourself to be an expert. And then you show up to the ED and everyone's like not doing anything. And you're like, what the hell? This is STEMI. And then you go home, you clear your car, like, oh, these docs are idiots. Well, maybe you didn't learn about like left bundle physiology at some point, or something like that. And yeah, we don't do, and I knew this conversation was going to eventually get to education, but I don't think we do the best job of educating our new paramedics. I just don't. And what do I mean by that? I'm not talking about educating them on any particular medical topic or clinical topic. I don't think we do a good job of teaching our paramedic students how to think. I just
That
don't
is
think
true.
we don't think about like critical thinking. And that then it's crazy because, for example, Hantavi shared the one article about like um what is it, pre-hospital antibiotic use, right? And if you actually, a great post, by the way. But after that, I saw a bunch of people posting about, oh, it's overdue, we have to use pre-hospital antibiotics. And if you look in the methods of that article, and I don't know if you're familiar with what I'm talking about, it was literally a viability study to see if paramedics would be able to give antibiotics at the correct time. That's
Yes,
all it
I am
was.
familiar now. Yes.
It had
Yeah, you
nothing
see a
to
lot of
do.
that with POCUS. People are,
Yeah.
and I support POCUS. I have changed my mind on it. I support it. But when I was a POCUS naysayer, I had person after person email or DM me these studies. They're like, look, here, it works for EMS. And it was the same shit. You read the study and it was like paramedic students in a simulated lab were able to identify, you know, cardiac tamponade. And it's like, it's a feasibility study.
Yeah. Yeah. And I'm not saying that's a bad thing. I'm saying that we have to follow the process. Especially, in Maryland, we have a very regimented system on how protocols develop. So, for your listeners that may not be from Maryland, Maryland has a statewide protocol committee where anyone that wants to start an EMS protocol, they have to write it up. They have to provide the evidence. They have to have a physician, an EMS medical director, like sign off on it, and then they present the case to the protocol committee. The protocol committee is a bunch of different people. I know that's different because in some places there's like regional protocols, right, or even jurisdiction specific protocols, where the medical director can basically say yay or nay. Part of that literature review, part of the research, you have to include good evidence. And what do I mean by good evidence? It can't just be this feasibility study of 30 candidates in a controlled lab. The big thing in terms of the antibiotics, I want to see hospital outcomes of people, right? There has to be a
Yes.
good trial that proves that pre-hospital administration of antibiotics, and I'm not talking about for open fractures, right? Like that's going live in Maryland this July. I'm
Yeah.
talking about like true septic patients, right? That have a bad pneumonia, they meet your sepsis
Yes.
criteria, and you have the ability to draw labs and give wide coverage antibiotics. Broad spectrum is what I was trying to say, and you start treating early. That's not to say that it's not going to be beneficial. What I'm saying is we got to do the work as EMS researchers before we get to that point, is what I'm trying to
Yes.
say.
And it also goes to show that people don't know what they don't know. I was
Mm-hmm.
talking to actually Bert Schiffer. He's an EMS physician in Pennsylvania. He's a great guy. I was supposed to record with him last week. He's actually coming over to my house on Wednesday to record. We were talking about antibiotics, and we don't know about antibiotics. Paramedics don't know. We're not trained this. And he said,
No.
you don't need to know it. And like you said, a pneumonia could be a complicated sepsis, but you have EMS providers saying, if we can get an antibiotic on board early, which may be true, but you don't know what you're dealing with. Like you don't know which weapon to use. I brought up the ANSEP. I said, well, why are we giving ANSEP for open fractures then? And he said, well, it's pretty much like settled. We know what the pathogens are. It's your own flora
Yep.
that is causing the infection. He said an ANSEF works on it. So like, yes, please, we know what the pathogen is. Give it. But there's so much stuff in EMS that people want to do, and they want to increase the scope of practice. That's all I hear. Paramedics in this system can do this and we can't do this, or we should add this. But I think before we do any of that, we need to be adding knowledge.
Mm-hmm.
Why do you want to use this tool? How's it going to benefit the patients? How's it going to benefit the population? Ask the hard question that people don't like asking. Is it worth spending the capital on something if it's only going to benefit 2 patients in your system a year? Like, could we spend that money somewhere else that's going to better serve the greater good?
We
I don't
had
know.
Dr. Arn Skolberg on. I think his episode. So we're recording. What's today? The 21st. So we
Yeah.
had him on. I think 2 weeks or last 2 weeks ago, because we just published our bioethics and EMS episode, and he was talking about the educational program for paramedics in Norway. And they have a 3-year bachelor's degree. That's kind of the entry level. And then you can do the critical care stuff, which is like a master's level degree. Um, and he said it, I believe himself. They do, with more education, they have less stuff as an entry level paramedic. So I agree with you, Mike. I think we can't just, and I think on the surface level, people would agree with us for the most part, that we can't just do stuff to do stuff, because there's a human being at the bottom of that, right? At the end of that, I mean, intervention. The one caveat that I would put to that is, I've had many physicians tell me that, oh, quote, you don't need to know that. And that's where I personally get a little bit, I don't know. I get a little bit weird about it, because I will be the judge of what I need to know, not need to know, right? As a personal paramedic. So like, as part of my personal journey as a paramedic, for example, I'm a big physiology nerd, in case anyone hasn't heard already, because I've said it 10 times. I was really interested in like the deeper physiology of why calcium helps with hyper K, right? And I had a physician straight up tell me, he's like, doesn't matter, just give him calcium. And I'm like, that's kind of defeating the purpose, right? And I mean, the guy was having a bad day, blah, blah, blah. But if someone wants to seek out the knowledge, go seek out the knowledge. Just make sure you're doing it in a way that is conducive to you efficiently learning the stuff. So what do I
Yes.
mean by that? You shouldn't go to and again, there's a ton of really good content out there, right? But I would have been flying blind without a formal education in physiology, because I would have started in the middle of where I should have, in the middle of a journey that I should have started way before. And what do I mean by that? A lot of paramedic students ask me, "Hey, what stuff on YouTube can I use as a good reference tool?" I say, "Listen, don't do anything. Right? For now, we're going to give you the information you need." Because if you go to stuff that, on YouTube or whatever, that you don't quite understand, that's going to throw off your current learning ability and your current where you are in your learning process. um, I know I'm kind of rambling here. I just wanted to make that point of, paramedics should be able to decide what they want to learn, but if you're going to go out and do it, learn it the right way. And I think that is partial to, number one, at least depending on the topic, formal education, but also getting information from a multitude of resources, not just one, because I think that's where the bubble comes, like you were saying earlier.
Yeah, I think that doctor, I see what that doctor was saying as far as you don't need to know that. But I think that is, yeah, probably not the best way to put it, because if I was training and I have trained paramedics, and I've put together a critical care transport course, and I do see what this doctor is saying. Like, we would pull the material together, and then I've heard other courses like going into like the cell wall sodium transport stuff, and maybe I'm just a simpleton, but I'm like, these people do not need to know this. They
Sure.
absolutely do not need to know this for the initial training.
Yes.
If they want to learn it as they progress to make them better, more well-rounded,
There,
yes,
there I go again.
there you go again. But
Oh
you can't just overwhelm people and carpet bomb them with information that is so esoteric and detailed that they're not going to be able to get the foundation. You got to crawl before you learn to walk, as they say.
Yeah, no, absolutely. I'm going to say this, and then I'm going to fix my camera again. No,
Yeah,
I absolutely agree with you. I think that a part of that, though, is people. I think many people don't do a good job of teaching that content to the best of their ability.
that is true.
Right. So then when you're sitting watching a lecture of like what's a great example, maintenance of sodium and potassium across the membrane, right?
Yeah.
If you have somebody that isn't good at talking about it, then you're going to be like, oh my God, why do I give a shit? Right. And they shouldn't be
Yes.
learning this. But if you have someone that can always apply it to, Elizabeth Wooster is our trauma director where I work, but she's been a flight medic and a nurse for years, um, and a flight nurse. And she is one of those people that's gifted with being able to break down complex physiological topics in a way that you could teach a middle schooler. And I think that's a hallmark of a good educator. And that's kind of goes back to what I was saying earlier about you have to have the right educators in the room that are humble enough but are knowledgeable enough to teach stuff like that. And that's why if you're a student looking for that content, you have to be able to know, and it's going to be trial and error, but you have to find the right people to teach you. Is what I want to say. I'll be right back. Let me see what I'm going to do here.
Yeah, you're good.
All right, how's that coming up now?
Yeah, very good, very good, very good.
All right, dude. I really appreciate you being patient with me.
I wrote this down before your camera crapped out. You were talking about the need to get the right people to teach.
Yeah.
That is another failing part of EMS education. Am I critical of people who have really not done paramedic work, teaching people how to be paramedics? Yes. On the flip side, I see a lot of paramedic programs hiring these, and they may be great paramedics. I am not saying they're like these know-nothing weapons of mass destruction, but you have these experienced paramedics who are coming towards the end of their career. They're retiring from the fire department or their agency, and they're like, oh, my retirement gig, I got hired by the community college to teach the paramedic students. Just because you may be a great paramedic does not mean you're going to be a good educator.
Yeah.
I had a guy in the DMs. I told him, or in my comments, I was like, I applaud your self-awareness, because he's like, I consider myself to be an excellent paramedic. I went into education. He said, I'm a terrible educator. Just like, I think I'm a good paramedic. I was a terrible administrator. So I think we have a lot of wrong people teaching paramedics.
Yeah, I'll tell you what though, the wrong person can also become the right person. I remember the first time I lectured pharmacology, It was garbage.
Fair.
It was garbage. I was horrendous, and the worst part was no one actually told me anything. Textbook stuff, reading off the slides, not being clear, not being concise, now, fast forward to today, I don't even use PowerPoint slides except for my 12 lead stuff. I do all whiteboard, right? Because I make it a point to review the content before I even, and make it a point to know exactly what my lesson plan is, and I tweak it, and then I whiteboard everything. So I think you can improve. It's just there is no link between being a good, well, maybe there isn't, I don't know, but there is no exact link between being a good paramedic and being a good educator. And somewhere in the middle is the field preceptor too, where
Yes.
and I would love to get your thought. I know we got to finish up in a bit, but I would love to get your thoughts on that.
Yeah.
How do you, well, we had an episode on this. How do you find a good preceptor, right? Because oftentimes you don't get to find one, you're assigned one. So what are some good signs, and what are your thoughts on that?
Oh man, that is such a loaded question. We could do like 3 more hours on this. You have to find a preceptor that is willing. Well, first, it sounds corny. The preceptor always has to be a patient advocate, because there is a fine line of realizing that they are a student that is going to be doing invasive skills and making important decisions for that person. So you have to have a preceptor who's going to realize that, but be a patient advocate, and always, be able to balance the learning process, needing to learn to let the student do skills, with, hey, this is an actual human. Like, I am responsible for this person. I can't just let this person poke them 92 times to start an IV.
Yeah.
But you also have to have somebody who is willing to let the student win some, fail. It is very, very difficult to, do I let the student screw this up? Is that ethical to do for the patient? Or These are big philosophical questions that you encounter for a preceptor. Like I've had to let students fail before. I will never let them do something wrong to a patient. I've seen people do that before
Mm-hmm.
where they're like, well, I think the patient's got CHF, but the student says, hey, I'm going to treat him for a COPD exacerbation. So, students got to learn, like, no. Like, that's not appropriate.
Yeah.
100% no.
God, no.
But I have had it before where, like, it's an 80-year-old that had 3 syncopal episodes. The 12 lead's good. They were initially hypotensive, but now they're good. And the student's like, I'm going to call the doctor and get a release to BLS. And I'm just like, I'm going to let you do that because I'm going to let you fail. It's not going to hurt the patient, and it's going to be a learning experience for you.
Because they'll never do that again.
Yes. And I'll sometimes like shoot the doc a text or call later and be like, hey, I was just letting the student fail.
Yeah.
But you have to find a preceptor that is able to balance all of that. You have to find a preceptor who's interested, because being a preceptor is a good stepping stone to being a supervisor. It's also a notch on a belt.
Mm-hmm.
And people in this profession love notches on their belts. They love to be able to say, oh, I'm a field training officer. So are they in it for the right reasons?
Do they want the rocker, or do they actually want the responsibility?
You also want somebody who's tough.
Mm-hmm.
And this is where Cody and I pissed everybody off in our podcast in December. I heard about that. Yeah. I'm a tough preceptor. I have high standards, and if I had a dime for every student over the last 15 years who's come to me and said, oh, I know you're tough and you have high standards, I'm going to learn for you, and then they disappear after a week, I'd be a rich man. I teach, I have high standards, I'm not nasty, but you have to have somebody that's not going to be your buddy. I have, as a young preceptor, been drinking buddies with my student before. It doesn't work. It's not good. You can't be like that, as I knock my seat down. So that was a lot of rambling, and I don't know if that answers your question.
No, it does, man. It's that professional boundary, and unfortunately, I have been guilty of, great, how do I say it? Blurring that line before. I like to think I'm a little better now. I've seen other instructors certainly blur the line, and
I don't fuck my students anymore.
Yeah, God, if only I could tell you stories about some instructors I know, man. Oh God. The problem, the problem with not drawing that line early is you're ultimately harming your students, right? I mean, why are we there as educators? We want to make paramedics that are one day going to not only be our partners, potentially, but also the folks that are potentially treating our own family members. And if you're not having that professional relationship, it's really going to harm that that instructor or student relationship. And you got to respect that before you respect anything else, I feel like. The other thing I was going to say is, so I haven't had the experience of having a long-term student, except I've had one long-term preceptee before. Everything else was, I show up to work and I have a student that day. The biggest thing I would say to listeners is, if you find yourself in a preceptee position, just be willing to, if you show up and say, hey, my name is XYZ and, I'm here for this. And I would really like to learn X today, right? Because that whatever you're working on. So that shows interest. That shows that you're humble. If you're a preceptor, the first thing I would do in the morning is check myself. How did I sleep? How am I doing? Am I pissed at the wife? Am I pissed at something else? Is there anything else that's going to damage that's going to damage that potential preceptee? And is there anything that I'm going to say that isn't meant for that preceptee, but I'm going to take it out on them anyway? Because if there's anything like that, you got to fix that before you ever walk through those doors. And honestly, that's probably a good set of advice for any day of going to work. But yeah, that's the last thing I'll say. I know we got to run. I feel like I've blabbed about nothing all day, man. Sorry. Well,
isn't that what a good podcast is? I mean, if you listen to Joe Rogan's podcast, you're like, what? I listened to this for 4 hours. What did they talk about?
Yeah.
But it was interesting to listen to.
Yeah.
Well, Moose, thanks for coming on, man.
Dude, I appreciate you, man.